Hello, and thank you for joining us for this webinar, Navigating Intimacy, Erectile Dysfunction, Incontinence, and Sex After Prostate Cancer. My name is Jeremy Patch, Senior Director of Patient Programs and Education here at Zero Prostate Cancer, and I'll be serving as your host. I'm excited for you to hear from our esteemed featured speakers, Dr. Andrew Sun and Dr. Shelley Imholte, joining us shortly. We recognize that dealing with ED and/or incontinence can take a real toll on your mental health and your quality of life. It impacts patients and their intimate partners. And so we hope today's discussion is honest, insightful, and encouraging. I'd like to share just a few housekeeping notes before we get started. Today's webinar is being recorded and will be posted on our website, zerocancer.org, later this week. As soon as the event ends, you'll see a link to a survey. We would love for you to participate so that we can get your feedback on this event and topics you'd like to have covered in future educational programs. Tomorrow, you will also receive an email with a link to the recording and the survey. Please submit your questions for today's discussion at any time using the Q&A box at the bottom of your screen. We'll do our best to get to as many questions as possible at the end, but remember, neither Zero nor our guest experts can provide individual medical advice, so please keep your questions general. I'd first like to thank our webinar series sponsors, Boston Scientific and Foundation Medicine. Their generous support makes events like this possible. Zero Prostate Cancer is the leading national nonprofit with the mission to end prostate cancer and help all who are impacted. We advance research, provide support, and create solutions to achieve health equity to meet the most critical needs of our community. Zero is proud to offer a variety of free patient support programs and educational tools. If you or someone you know is in need of resources at any time while facing prostate cancer, please share these tools with them. In light of today's discussion, I want to reiterate that we don't want anyone to suffer in silence or walk their journey alone. These programs offer relief and a chance to connect with others who are experiencing many of the same things you are as a patient, survivor, or caregiver. Our 0360 helpline provides case management to help patients and their families navigate insurance and connect with financial assistance and emotional support programs. We also offer 2 peer support programs. Our mentor program makes one-on-one connections where our support groups are offered virtually and in person. And both our mentors and support group leaders go through training. They're well-versed in connecting with patients and supporting patients in their journey. If you prefer online support, you can also connect with others affected by prostate cancer in Zero Connect, our private Facebook group, or on our prostate cancer forum, which is powered by Inspire. And that's an option if you're not on Facebook or don't want to be on Facebook. Join us for our next webinar, which will cover advanced imaging and diagnostics on May 22nd at 5 p.m. Eastern Time. And we'll drop that registration link in the chat so you can know when that is and can register. We would also like to invite you all to our educational summit happening June 3rd through the 5th. During this virtual summit, we will have sessions on treatment updates, active surveillance, insurance, expert Q&A, and more. There will also be support groups and other ways to connect with attendees, Zero, and our partners every day as part of our summit. We're excited. We're using a new platform that offers a lot of engagement opportunities, so we're excited. We hope you enjoy it. Register now at the link provided in the chat. Now, please join me in welcoming Dr. Andrew Sun, urologist and director of Men's Health and Urology Partners of North Texas, and you can see a little bit more about him on our slide here, as well as we're pleased to be joined by Dr. Shelley Imholte, a licensed social worker and specialist in human sexuality, and she will join us shortly for the discussion. But we're thankful to have you both as part of the conversation today, and I'm going to first pass it along to Dr. Sun to get us started. So, Dr. Sun, can you get us started with a brief presentation so we can all begin the conversation with a baseline understanding, including some important ways to manage both ED and incontinence?
Absolutely. Thank you, Jeremy. Thank you to Zero for hosting this. And thanks to all of you for taking time out of your evenings to hang out with us and talk about these issues. My name is Andrew Sun. I'm a urologist. I'm a very specific kind of urologist in that I completely have given up all of my normal urology stuff. I don't actually treat prostate cancer anymore, kidney cancer, all of that stuff. I entirely focus on basically men's health issues. And within pertaining to prostate cancer, that's basically erectile dysfunction and stress incontinence, two unfortunately very common things. And so that's what I do in our practice. UPNT, we're a large urology practice in mostly Fort Worth, mid-cities, Irving, Arlington, that kind of thing. And that's kind of some stuff that I want to share with you today. So, sorry, that's me, that's us. So two big things to talk about: erectile dysfunction and stress incontinence. Essentially, I would tell you that what I tell my patients is like 100% of patients undergoing treatment for prostate cancer will experience some degree of erectile dysfunction. And a very high, maybe not 100, but like some very high number, 90, 80% of patients will also experience some degree of urinary dysfunction, usually incontinence, especially with prostate surgery removal. But erectile dysfunction is universally true. It's not a question of if ED accompanies prostate cancer therapy, it's a question of how much. And sometimes that depends on how bad it was to begin with, but also just, where we're going to be and what we're going to do about it. Remember that erections are a two-step process. It's not just getting blood into the penis. You have to get the blood into the penis, and then you have to keep the blood in the penis. A lot of times, there's two types of versions of ED you get with prostate cancer treatment. One is just a very difficult time getting an erection at all. That can be from nerve damage. That can be from, blood vessel dysfunction. But a lot of men will have this sort of venous leak physiology after prostate removal or after radiation, in which you can still attain the erection, but it's very difficult to maintain the erection. And that's usually due to the veins around the prostate not being able to close off tight enough to keep the blood trapped in there. And that can be equally as frustrating because, yeah, you can get it up, but can you keep it up, long enough to be able to use, basically? So those are the two steps of erection. Why does that come with prostate removal? Well, because the prostate sits in between the bladder and the penis, and so you're taking something out of there, and then you're connecting the two ends. Something that I think people don't talk enough about, but that I would say is universally true, is that when you have your prostate removed, you lose a little bit of length on the penis. Not a very popular thing to think about or discuss, but you are taking something out and pulling two things together. Now, mostly that's the bladder being pulled down to the level of the urethra, but it does tether the urethra a little bit, and so sometimes you can get this kind of puckering, or people describe it all sorts of ways. It like their penis is like a turtle. It's kind of like re-uncircumcising, where the skin is kind of hanging a little bit and stuff like that. And we can combat that a little bit with things like vacuum erection devices and things like that in sort of a peri-prostatectomy rehabilitation protocol that we do with our patients. But there's other things that can be helpful, but nothing replaces getting erections, right? The penis is a muscle, and like any other muscle in the body, if you don't use it, you lose it. And so you need to get that blood flow or some kind of stretch in the penis, or else what you can get over time is a little bit of atrophy or shrinkage of the penis, two words that should never be used in the same sentence, but unfortunately, we have to talk about it that way. Super common. You can use whatever statistic you have, but for everyone on this call, I'm sure you would agree that the rate of some degree of erectile dysfunction after prostate surgery is 100%. And so, and it can get better, especially with modern techniques. It's much better than it used to be. The days of open surgery are gone. Now we use robots. We're pretty slick about it. But even the best robotic surgeon in the world, you still have to move those nerves. And just touching those nerves injures them a little bit, stuns them a little bit. And it can take a year, it can take 2 years for that function to come back. But realistically, even when it does come back, it's never quite as good as it was before, because no patient ever had prostate cancer and came out with better erections afterwards. It's just not the case. Um, so didn't click that. So what are the treatment options that we have? The treatment options are the same for everybody. It's just that specific to prostate cancer patients, some of them will work better than others. So you got pills. We do pills, Cialis, Viagra. They work. We actually give them every day, like a low dose Cialis around the time and after surgery. But because the pills actually work through the nerves, and because the nerves are usually the thing that's most injured in prostate cancer surgery or radiation, the pills tend to work a lot less well. Vacuum pumps, if you've ever tried one, it's not a very useful tool to actually try and have sex. It can be an adjunct, but by itself, it's not like the greatest thing in the world. But you can use it as a stretching tool. But mostly we concentrate on the higher order interventions like penile injections and penile implants. Urethral suppositories is mostly a thing of the past. Shoving something up there is not exactly a very pleasant situation. So it's mostly going to be injections and penile implants. There are some patients, especially those younger ones, who have good erectile function beforehand. Pills may still work afterwards, but if the pills were already not working that well beforehand, afterwards they may be not very effective. So injections are injections. That's a fairly easy thing to explain. You stick a needle in the penis every time you want to have sex. It works. It's not the funnest thing to do in the world. It's not the most spontaneous, but it's effective. The penile implant is sort of let's think about it as like a knee replacement, but it's for your penis, right? If you have a bad knee, what do you do? Athletic injury, whatever you want to call it. You can take pills, you can do shots, and you can get a knee replacement. And if you have, a bad penis, you can take pills, you can do shots, and you can get a penis replacement. In this case, a inflatable penile implant. These things have been around since the 70s. And basically, it's a guaranteed way to get an erection. It's a balloon pump that you place inside the penis, and a little switch like that you operate. The pump is in the scrotum. If anybody had those old shoes that you like pumped up, it's basically that, but it's in your scrotum, and you're pumping up your penis. But once it's pumped up, it's guaranteed to basically work and stay up. So very, very effective technique, kind of like a knee replacement. For the guy with like sort of end stage knee situation, a way to restore function, albeit perhaps not a time machine to go back to when he was 20. Oops, things to expect from, go back one. General sort of tidbits about the procedure. This takes about an hour. It's an outpatient surgery, meaning you go home the same day. You are under general anesthesia, but not necessarily needing an entire tube down the throat. It's a 1-inch cut. You get all that in there with 1 inch. About a week until you can return to sort of light activity. About a month until you can use it. They last about 15 to 20 years. And the biggest thing is Medicare completely pays for these things. I know it's shocking, but it is the case. Medicare and many commercial plans, not all of them, I can't tell you exactly which, but definitely for Medicare or anything government, TRICARE, VA, Blue Cross, federal, these kinds of things, they're all fully covered. And for many patients, especially those with prostate cancer, if there's any type of patient for whom this surgery will be covered, it is a prostate cancer patient. So those are some general ideas about the erectile situation. Lots of options. I just want you to keep in mind, however bad it is, there's always something we can do. It's a rare day that I have a disease process as a physician where I can guarantee somebody any kind of outcome, but I can reasonably guarantee anybody who wants an erection that I can get them an erection. It just depends on how much work it's going to take and how much they're sort of willing to go through, right? So I think I'm 6 minutes in, so 4 minutes on stress incontinence. This is another thing that occurs with prostate cancer treatment, leakage of urine. And like erections, it's the worst at the very beginning when you have surgery, and then it gets better. And with radiation, it's usually nothing in the beginning, but over time, you can get a little bit of, it's not so much leakage necessarily, but you can get voiding dysfunction, urgency, frequency, and that kind of thing. The same reason is obvious because prostate, which comes from the Greek word for guardian, is sitting in front of the bladder, and it prevents you from leaking. It's one of its few functions. Prostate doesn't do very much. It makes semen and it causes you problems, right? So, but one thing it does do is it prevents a little bit of the leakage of urine. So when you lose that, you don't have an internal sphincter, i.e. the prostate anymore, and so you can leak. Almost always you'll leak in the beginning. Fortunately, for most patients, that will get better, especially when you do Kegel exercises over time. But for many patients, you'll still have leakage. Now, it may be florid incontinence, and it may be just a little bit of leakage, and it may only be leakage when you get aroused or have an orgasm or something like that, but leakage can definitely still be bothersome and can persist. There are other causes of it, but for the purposes of the discussion, we might as well just stick to the most common cause, which is removal of the prostate. So we can skip that slide there. So what can we do about it? Well, you can basically do what a lot of people do, which is they dehydrate themselves. Leakage is it's an embarrassing situation, and it's a devastating quality of life complication. The concern and the fear, I mean, you guys know much more than I do, but not being able to go out and do your normal life stuff because you're worried about leaking all the time, it's terrible. And so a lot of people, cope by basically doing something that's not very healthy, which is they just don't drink any water, and I guess you make less urine that way, but it's not exactly healthy. You can do what we always recommend, which is some degree of physical therapy. Kegel exercises or dedicated physical therapy can be very helpful in helping to regain some of that muscle strength, to prevent leakage long term. And you can wear pads, you can use a clamp, you can have a catheter. These are all basically coping strategies. Or you can fix it, right? And as part of the reason why I inherently gravitate towards surgery as opposed to medicine is because I like to be able to fix things, and it's very satisfying for me. It's very satisfying for the patient. So we have two fixes for incontinence. We have a sling, which is more of a passive fix, and a sphincter, which is an active fix. The other way you can think about it is that this sling strengthens your existing sphincter. So if your leakage is what we would say mild to moderate, two pads, three pads, something like that. Not just like leaking all the time, but cough, laugh, sneeze, lift something heavy and you leak. The sling is nice. It's a 1 hour surgery. We make a little incision about, let's say 2 inches long in the perineum, kind of behind the scrotum. Put in this piece of mesh, tighten up the sphincter, the urethra, after which you pee like normal. You just don't leak anymore. It's a beautiful little surgery. It works really well. And, it's a 1 hour outpatient deal. The sphincter is sort of the bigger approach, right? It's a little bit more involved with surgery. Let's call it 1.5 to 2 hours. And in here, you're putting a donut. Imagine a little balloon shaped like a donut around the urethra, and it's basically always closed. So your urethra is basically being pinched shut by this, balloon, which means you don't leak at all, which means you could take the worst leaky guy in the world and you cinch him up and he's not leaking. But then how do you open the thing? You have to make it open. So you have to operate this. It does take a little bit of work, which is you have another one of these little switches inside the scrotum. Isn't it great how we just put everything inside the scrotum because you don't have a lot of places in the body where you have like a big empty sac that you could, put stuff into. So, and you don't have to take out the testicles to do this, right? Those are still there. You just put it next to it. So this little pump guy down here, when you squeeze it, you basically open up the sphincter. So when you're walking around passively, the sphincter is shut so you don't leak. And then when you go to the bathroom, you just reach down, feel for the pump in your scrotum, squeeze it, it opens, you pee, and then it closes on its own. All of these devices are all completely hidden, completely internal. Nobody will ever tell that you got anything going on just by looking at it. But it's a great way to, fix even like the worst cases of leakage. Even in patients that have had surgery and radiation, and all sorts of stuff, you can still do these surgeries, and you can still make people dry and massively improve quality of life. Outpatient procedure, small incisions, home the same day for basically everything. A few weeks of kind of taking it easy. You don't want to like move something out of place. So let's just say a month, and then you're back to living your normal life again, which is a very great thing. And part of the reason why I went into this field specifically is so that I could specialize and give patients these sort of quality of life treatment options. So now me and my, fellow doctors in my practice, we basically work as a team where I see a lot of patients for testosterone and all this kind of stuff. And then I, give them testosterone. And at some point in the future, whether or not we're doing testosterone, they get an elevated PSA. I send them to my partners. They get prostate cancer. They treat the prostate cancer. And then I treat issues that can arise afterwards. And it's a very lovely kind of system. So that is it's just about 10 minutes, talk there. Thank you for your attention, and, stick around and happy to continue the conversation.
Dr. Sun, thank you so much for that great presentation. You really did. You kept yourself on the clock. I'm impressed.
Yeah.
What advice would you give to a patient who's been diagnosed with early stage disease and and they're trying to decide on treatment, but so they can best advocate for themselves and the importance of their quality of life, including their sexual health, to their healthcare provider?
That is a fantastic question. I guess they're still in the phase of deciding between active surveillance, radiation, or surgery. Those are still pretty much the main three treatments. We could go down a whole rabbit hole of like focal therapy and some new things, but let's just stick to the big three. Definitely as a field, I think all of us urologists would admit that, 20, 30 years ago, the prevailing thought was if you have a whiff of prostate cancer, you cut that thing out, right? And then whatever happens, happens. And we were really aggressive and really good at removing cancer because of the big C word, but not very good at managing the side effects. Nowadays, I think, fortunately, we're a little bit more nuanced there. We're really only trying to remove the cancers that really need to be removed. It's a very weird thought, but prostate cancer is unique in that there's a lot of prostate cancer that doesn't have to be treated. And so I would, like, if it was me, I would want to delay that treatment as much as reasonably possible until I basically had to do something. not because it's like gotten really aggressive, but because I have decided that it's worthwhile to get treatment, and my lifespan and versus the duration of time of the aggressiveness of the tumor is basically worthwhile to do treatment. Then, deciding between surgery and radiation, they're both highly effective approaches to treat the cancer. You look at the 10-year survival, you're talking about a 2 or 3% difference. If you had to pin me down, you would say the younger man with the more aggressive cancer is more likely to get surgery. The older man with the less aggressive cancer is more likely to get radiation just because there's less sort of side effects. But regardless, I think that we are not good as a field at having the folks that are really good about treating cancer also be really good about treating these kinds of things. I could try to make an excuse for it and say there's just too much to know out there to be hyper good at like everything in urology, but this is just a thing that we're still struggling with as a field. That's why I went into what I do. It is definitely always helpful and encouraged for the patients to advocate for themselves. Ask the questions and tell them to be real with you, right? What is this going to affect, or how is this going to affect my erections? And honestly, any answer, but it's going to hurt them a little bit is probably not the right answer. And, just kind of say, I really, really care not just about treating the cancer, but about ensuring that the quality of life afterwards is good. And my extremely cheesy, but I like it, sort of quote that I use with the patients is, hey, Dr. X is a great cancer surgeon, and he is here to give you years on your life, right? And I'm here to give you life to those years. And it's so corny, but I love it because that's really how we kind of work together. And you can't just do one without the other. And so this is a very long-winded answer to your question, but essentially personal advocacy for caring about those things will trigger, hopefully, your surgeon to also think more about those aspects because, in fairness, what they're concentrating on at that time is probably how to treat the cancer, 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 cancer. But there are some things that you can do proactively to help ensure that your quality of life situation is better afterwards as well.
Thank you for that. I appreciate that. I also just want to thank you for your frankness when you started out your discussion and your presentation, because I guarantee you there are men and even caregivers on this call who did not get that level of frankness when they were first meeting with a urologist or maybe even an oncologist, and the expectation that dealing with ED and incontinence is going to happen.
Right.
And that they're just, we talk to so many men who are gobsmacked by how real the struggle is and how the depths of the struggle sometimes. And so, I just want to thank you for kind of level setting with that conversation. Dr. Imholte, we are so glad you're joining us for this conversation.
Thanks.
We don't always, we're happy to have you both on because we tend to do one or the other. We tend to have conversations with the medical side or the surgical side and managing the side effects. And then we, tend to have our therapists separately, but I'm glad you kind of both can tag team this and we can have a fuller conversation. But so tell us, Dr. Imholte, a little bit about your typical first conversation with prostate cancer patients or survivors and their partners when they first seek out your help.
Usually by the time folks get to me, it's been a couple of years, if not 6 or 7, which is problematic to begin with, which is one of the reasons I appreciate Dr. Sun's model, because it is different. By the time 5, 6, 7 years roll around, you have some pretty entrenched dynamics that are difficult to then sort of pick apart and make change. So usually my very first question is like, what do you know about yourself and change? Because it gives you a lot of information. Prostate cancer changes the individual while also changing a couple or multi-partner relationship, and understanding how you approach change is a good insight into where the barriers are likely to show up in your prostate cancer journey. So that's usually what I ask, because whatever you resist persists, right? Like, so a lot of times we want things to work right away. I appreciate Dr. Sun's presentation because there is this reliance on medication that I see too, of it's not working, it's not working, it's not working, and there's not really a full understanding of its connection to the nerves, and then of course blood that gets into the penis, and if it gets into the penis, can it stay in the penis? So as you can imagine, if it's 2, 3, 4, 7 years, right? There's going to be atrophy. There's going to be a longer process of unraveling what the dynamic has been since then. When we hear the word cancer, we usually want to stay alive. And so we think that becomes the focus, especially for partners or multi-partner relationships, is to stay alive. And the other pieces sort of take a back seat, right? Sexual pleasure, sexual satisfaction, practice, and how you become sexual in a different way. That's not an easy process. So, yes, my first question is usually like, what do you know about yourself and change?
That's an interesting question and perspective, but I appreciate that.
Oh,
And what I took away,
Sparky.
yeah, and what I took away too from what you said is don't wait too long. Like
Correct.
patients are often waiting too long and they're just struggling and struggling and
Yeah.
hoping and
Yeah.
waiting for it to get better.
Right.
So yeah.
I mean, ideally, I'm an advocate of sexual health, so I'd love to see that be more prevalent and accessible to all persons in all situations, but we don't necessarily live in a culture like that. Um, but something that I think can be really valuable is if people think about sex counseling versus sex therapy. I'm a sex therapist. I can also do sex counseling. Counseling, I'm not going to look at like family of origin or how you learned about your sexuality or how it was shaped through your lived experiences, right? It's going to be more focused on what's happening right now. Right. Sex therapy is going to be a more in-depth thing. It's like rebuilding your sexuality. So you sort of have to go back and pull it apart in order to rebuild it. It's like a restructuring of your sexuality. So you could talk to somebody that's a sex counselor, and that's going to look really different than therapy. And you can also engage with somebody in therapy, and that's going to take somewhat longer. I think it's has a longevity piece to it, but it's not for everyone. Mhm.
Okay. Appreciate that distinction. Thank
Sure.
you. Dr. Sonneman, kick it back to you with, and just wondering if you see, building on what Dr. Imholte said, if you also see where patients are struggling with this too long before they maybe even approach you with how bad it may be.
Absolutely. And it's unfortunately probably still more the norm. When I started my career, our default when I was in residency was like you would basically wait 2, 3, 4 years or just until the patient kind of told you that it was a problem instead of actively asking them those questions. It was just like, oh, well, your PSA is undetectable, so great, have a nice day, see ya, and that was it, right? And so it was by making it up to the patients to like actively voice that, you've increased the barrier of so much. There's a lot of understandable. I mean, ultimately, of course, I don't knock on my colleagues. They save people's lives, and there can be a significant hesitation sometimes on the part of the patients to then say, well, thanks for saving my life, but got these things going on, so it takes a long time. And it's part of why in our practice, we essentially created this like prostatectomy survivorship program where one of us from the men's health team or somebody is actively engaging with the patients every 3 months, basically for the first 2 years on these quality of life issues, in addition to checking the PSA, has been really helpful because from a psychological perspective, as Dr. Imholt was saying, to get these ideas entrenched in, and then from an anatomical perspective of, well, call it for what it is, like penile shrinkage, I would much rather get the guy to definitive therapy in a year than in 5 years. One, so he had 4 more years of good times, and one because I don't want to wait 5 years for some contraction to occur because unfortunately, by definition, I only get to operate on unhealthy penises, right? I never get to operate on like nice, healthy, stretchy penises. And the longer it's been unhealthy, the worse sort of anatomy I have to work with. And I'm a pretty good surgeon, but I don't have a time machine. I can't just completely make people like they were 20 again. I can make it work well, but yes. So I think as a whole field in this like survivorship men's health world, one of our big goals is to not only get people therapy that they may have never known existed, but also to shrink the time. I think there's some statistics about it being 7, 8, 9 years from the time they have their prostate surgery to like when they get, their final definitive therapy to work again. That's way too long, right? That should be months, not years. So.
Okay, thank you for that kind of level setting. I appreciate both of you. And that's where I think my next question is flowing into that, because many viewers of this webinar and video may have been dealing with ED and intimacy issues for a long time, and they're probably recognizing themselves already in this conversation. What advice do each of you have for those folks and their partners who have been struggling a while or have tried different things and it's not working? What would you each offer them? Dr. Imholte,
Well, one, I
we'll
would
go with
say lighten up, right? It becomes so serious, right? And sex is about being playful, right? It's about being really present. It's about total engagement as you can, as much as you can. And there is some evidence, at least in my experience with cases of like, if there were sexual intimacy issues prior to prostate cancer, they are then compounded by prostate cancer, right? And so that's where the sex therapy versus sex counseling can look really different, right? But some is like, if we're going to make a change, we have to be a little lighter with ourselves, right? So even if you waited 7 years, right, and you have the atrophy, the entire body is an erotic palette, right? Like you can have sensation throughout the body. You can have full body orgasm throughout the body, but it does take practice. And so that practice does not work well when it becomes very task oriented, right? It works best when it's more playful and creative and mindful and silly. So in a way, there's an opportunity to sort of go backwards and be really ridiculous around sex, just like we did, I don't know about everybody else, but in high school and you're in the back seat and you're playing around in that way. Like learning that. I've had people go sit in your driveway and make out again, right? Like so that you have an experience that's not so heavy. Cancer itself is heavy. It wouldn't matter what kind of cancer, right? Cancer, the word is heavy, right? But once it becomes really entrenched in prostate cancer recovery, that kind of heaviness and that seriousness is very difficult to then be playful, right? There's almost a sort of forcing it to happen, right? And that doesn't work well. The penis doesn't respond well to being forced either, right? The arousal and nervous system does not respond well to that either. So some of it is to be more playful and light and to just be really present in the moment.
From my perspective, well, I'm a surgeon first, which probably means I'm not the best at these things, but I will say something for sure from my experience, which is that, men dealing with prostate cancer who are married, I'll just use heterosexual couples, right? So I generally find there to be two situations. Either the spouse is like very encouraging and on board with like kind of getting the problem fixed and treatments, or the guy might come and it's like, yeah, I got pretty bad ED. I've tried this and that. It's not going. And my wife is like, don't worry about it, honey. Like it'll be okay. Like I still love you, but man, it just really affects me. And sometimes we go down the pathway and I get them to doing a penile implant and I see, depression, anxiety, like all of this stuff around sex that shouldn't be there. And it really weighs on the mind. And the best analogy that I've learned to come up when I then get the opportunity to speak to their spouses about it is essentially a similar one to breast cancer in women, which is that the vast majority of women who have breast cancer after having a mastectomy will elect to have breast implants, right? It's not necessary strictly per se. Your husband will still love you even if you don't have them, but there's a psychological element to that surgery from a personal sense of self-confidence that is really almost necessary. And I think for many men, after prostate cancer is part of the reason why I hated treating prostate cancer is because 95% of men with prostate cancer have no symptoms. This is something that they get told they have. It's a blood test. They're like, oh crap, I guess I got cancer. I feel fine though. And then you do this really radical surgery to them. And then they feel all sorts of things, including depression, anxiety, and the psychological sense of loss of manhood, right? And I just implicitly get that as a guy. And so that creates a certain almost like classic psychological milieu and when the guy comes in, and that can affect the relationship, that can affect their work, that can affect their self-esteem. And being able to fix that, whether it's injections, whether it's an implant, let's just use the implant as the example, to give that guy back a 100% absolute sense of rock solid confidence that when the time comes, he can perform, gives him a psychological freedom that is truly gratifying and alleviating. And sometimes that's the biggest benefit, not even the ability to have sex again, but that's the biggest benefit, is that you've helped him psychologically. And I think when spouses sort of understand that piece of it, because they may have seen some of this change in their partner, it's just a really big revelation, right? And so some of it is for the actual act of having sex, a lot of it is for psychological self-esteem, some of it for, this sounds trite, but it's just about getting the penis to hang a little bit looser, because you just want a better handle to hold when you're peeing. And like, that seems trivial, but like, that's really important to a guy. Just be able to reach down there and have a handle to pick up, because sometimes it just shrinks in so much that you got to like dig it out. And then if he has a little bit of atrophy and urinary leakage, well, then he's got to run to the bathroom, but then he can't get the penis out in time. And now you're peeing on yourself. And it's just this very negative everything that you can kind of correct, which is, yeah, it's cool.
Okay.
Yeah. Yeah, I agree with those pieces too. I think that there's also this piece of like, if you were in a partnership, right, then ideally you work at this as a unit, right? It's not just the individual. I see a lot greater benefit when the unit is working together early, right, on this, because it gives them an opportunity to recreate their sex life, right? I see it in like, that's kind of a benefit out of all of this, right? Is that then they can recreate that together, right? Versus it being really separate. You know, some of what I ask men that show up individually about, what is their relationship to their penis? Do they know what it looks like underneath? What's their relationship to their testes? How has that been? Right? Like, and it's often just for use. But this is completely changes anatomically, right? Which then impacts the entire psyche of the male. Mhm. You know, so some of that is recreating your relationship with your body, right? How you are sexual, what pleasure actually looks like, which that's no easy feat. Mhm. Mhm.
Yeah,
Yeah.
I
Yeah.
agree. Thank you. I again, and I'm glad we're having this conversation with both of you to talk about the
Yeah.
body and how it
Yeah.
responds, but then also the mind and how they work together.
Yeah.
Dr. Imholt, how can people find a sexual health specialist, counselor, or therapist like yourself to help them improve their relationship and intimacy?
Well, Google's always our first start, right? But you can find a sexual counselor, sexual educator might also be helpful, or a sexual therapist. There is an organization called ASECT, and I will send the link. It's the American Society of Sexual Educators, Counselors, and Therapists, right? And they have a directory that's nationwide. It might even be international at this point. So that's a good resource to do that. One is some urologists have connections. I know I'm connected to several urologists in my area, and make myself known there, because I like to work with this particular area because it is such an opportunity to change the entire system. Mhm. So there are those.
So, no, those are helpful tips, but I think also just, it looks
There
like
it
we're
is. Thank you.
dropping
Mhm.
that in there. Thank you. The directory. But I think too is just a good place to start is talking to someone like Dr. Sun or your urologist, your oncologist, hospital social worker, whoever you might be working with, to ask for a referral as well could be a good place to start. But keep that certainly directory in the back pocket, I think, too, if
Yeah.
needed. Yeah.
So
To both of you, what's one thing you hope our viewers leave with after today's conversation? Dr. Sun, go ahead.
Yeah, I would say that the biggest thing, because, presumably everybody on this call has already either, experienced a lot of this or whatnot, is that just know that there are ways to fix things. There you may have had the problem for 6 months. You may have had your prostate surgery yesterday. You may have had it 20 years ago.
Hmm.
Where there's a will, there's a way. And basically, fortunately, technology advances. There's whatever we have today, there's going to be new stuff coming down the pipeline. I work with some of the companies and some R&D, ventures in terms of like trying to develop the next generation of treatments. I can tell you that like, someday soon you may be able to have a lot of these functionalities controlled at, the touch of your smartphone, right? So that'll be interesting. But whatever we're going to get to, if with how fast AI is going, who knows what we got. But even like as of today, we have very effective and very safe methods of restoring function from both the leakage standpoint and from the sexual standpoint. It just takes a little bit of work. It takes finding the right person, matching the doctor and the patient and what they want to get out of it. But we can do it. And if you live in DFW, of course, I'm happy to see you.
Yeah, I would definitely say that there is hope, right? Because it can feel like all hope is gone. But I think there is a lot of hope. There's certainly more research that's happening for the future, but there's definitely hope in recreating that sexual relationship to even feel satisfied.
Well, thank you both for that. I think that's a good place to end our conversation. But now we want to turn to questions that are um,
Oh, I had a question for Dr. Sun. Can I
oh,
start?
yeah, no, go ahead.
Okay, great. You know what, Dr. Sun, I appreciated your presentation. I was looking at, like, can you have a artificial sphincter and an implant?
Absolutely. Lots of
Wow.
yeah. It's a lot of stuff in the scrotum. You essentially have two balls and two pumps in there. But we have patients that have that. Fortunately, not that many because it's got to be that's pretty bad incontinence and that's pretty bad ED, but they do go
Yeah.
together. But yes, you can do both. You can do one or you can do a sling and an IPP. Um,
Yeah. I get
Sometimes
that.
I'll do this technique where if the guy has just a little bit of incontinence, but specifically a type of incontinence that is associated with arousal or with orgasm. So they have what we call arousal incontinence or climacturia, where they're
Yeah.
orgasming and they're like, well, there's still fluid coming out.
Mhm.
It's not semen because you don't have a prostate, but it's probably some urine. You can do a implant with a little tiny dynamic sling between the two arms of the implant. If you imagine the implant's like a balloon, and when it's deflated, the sling is loose, so you pee. And when you inflate the balloon, it tightens the sling,
Right.
which crimps on your urethra, and then you can't leak anymore. And so you can fix the
Oh,
erections and the leakage kind of situation at the same time. Yes, we have, of
yeah.
course, lots of combinations of things that we can do.
And one of the things that I also heard, sorry, Jeremy, I'm definitely going to get to your question. One of the things I also hear after a penile implant too is not only the change in the appearance of the penis, right? Usually you lose some length in that, but also the sensation. Um, the sensation changes also. So I do a lot of work around spreading the sensation throughout the whole of the body versus
Mm.
the focus on the penile shaft, frankly.
Yeah. Yeah.
Um,
I think a little bit of it depends on technique. The most of the dorsal nerves on the penis are on the top in the middle.
okay.
Mostly I try to operate on the bottom to stay away from that area, such that in theory, you should not be directly affecting the nerves onto the head of the penis if you're not like cooking anything in that area. So you just try to stay far away from that. The one thing, it's always like something that I do have to kind of mention, which is that because of course my career is doing penile implants, I believe that the correct way to think about it, and this is like I will plant my flagpole here, is that penile implants don't cause you to lose length. What they Two things are true. One is that by the time a guy gets a penile implant, especially if he waits too long, the penis has already lost length, and then you can only put an implant into what he has. The second thing is that the implant does not inflate the head of the penis, so you still have to rely on
Right.
your natural erectile function. And we can still use Viagra, we can still use stuff like that to get the head to engorge a little bit more, which can increase sensitivity. And then the third thing that's true is just a physics thing, which is that a high pressure blood flow is always going to be able to blow up a balloon a little bit more than putting your hands inside the balloon and stretching it out from the inside. But
Mm.
if you stretch it out like that every day for the next year, you'll also loosen things up. So, we tell people immediately after implant, it's one thing, but if you use this thing every day, like we teach you to for 6 months, 9 months a year, it's a balloon. It only goes in one direction. You can actually stretch this thing out. And sometimes you can actually reverse some of the atrophy that has occurred. I don't promise it, but with enough,
Right.
use and some good anatomy in your favor, non-diabetic, you can definitely get a little bit of improvements over time, actually, as well.
Thank you.
Yeah.
Thanks, Jeremy.
Yeah, no problem. First question is somebody saying they had and this actually came in ahead. This was emailed ahead of the webinar, so maybe they've changed their mind. But I had a prostatectomy 14 months ago. I've not been able to have a full erection while taking trimix and quadmix. Is there a period of time that this shall pass, or is there another solution? My surgeon said no nerves were damaged during surgery. I am against penile implant, but again, maybe they've changed their mind after your presentation, Dr. Sun.
Yeah. And I think a lot of people are intrinsically, this is probably true 50% of the time, I mention the implant, they're like, whoa, that seems a little much. And yeah, it looks scary. If you look at the model, it looks like a lot of stuff. I'm like, 45-minute, 1-inch outpatient surgery, go home the same day, works for 15 years, Medicare pays for it, 100% guaranteed erection. Really not that big of a deal. You wouldn't have that reaction to a knee replacement, but you also wouldn't do a knee replacement right away when you're still taking pills. But with 14 months, most of the healing has already happened. I mean, you can get a little bit. We think about 70-80% of the improvement happens the first year, maybe an extra 20 to 30% the second year. And after that, the curves kind of overlap because you're just getting older. And so if you're already on trimix and quadmix, the likelihood for you to not need trimix and quadmix anymore in another 6 months or something like that, it's not zero. It's just not great. And so therefore the solutions are trimix and quadmix or a penile implant. My goal is in those patients is to basically support them if they want to continue using trimix. Usually at about 2 years, I tell them, look, man, just to be honest with you, it's probably not getting any better than this. Or to try and see if they would, go for an implant, because I just know that when they get it, they're just going to be a lot happier, afterwards. So.
Thank you. Another question is, what is the success rate of the male sling post-radiation therapy?
Not great. In fact, the general teaching is to not do a sling in patients with radiation. The urethra is thinner. You may have a higher risk of like mesh complications because of the tissue sort of strength. You can still do it in rare circumstances. You can still get some improvements. It's just not the ideal situation. Sometimes those patients, especially in patients who've had, usually leakage dramatically worsens like after radiation. If they had a surgery. The classic situation is they had prostate cancer, they had prostatectomy, they had some leakage, it wasn't awful, but then they had like a recurrence and then they got radiated. And then it really goes downhill. Those patients oftentimes are best served with a sphincter, an artificial sphincter.
Appreciate that. We've had a couple of questions about climacturia, and leaking urine during sex or during orgasm. How common is it, and can it be managed or treated?
Yeah. I think it's very common, probably because I just happen to ask people about it. And I think, again, it's one of these things that if you don't ask the question, a lot of people won't tell you. But it's really just a very, very mild version of incontinence. And incontinence is always on a spectrum from the worst thing you can do is leak in the middle of the night without even knowing it. That's like florid incontinence. The next thing is like you leak a lot. You have to wear a diaper all the time because you don't know if it's coming or not. Then it's like the most common situation, which is I'm mostly okay. I don't leak at night, but if I lift, if I cough, if I sneeze, when I swing a golf club, that's when I leak, and I wear 2 pads a day just to prevent it from happening. And then some people get lucky and they don't leak ever, but then the most mild version of leakage that's still leakage is I only leak when I am aroused or when I have climax. Because what is a climax? It's a rhythmic contraction of the vulva, muscles, right? And of course, there's a lot else that comes with it. So it's actually quite common. It can be certainly bothersome, obviously, like in a lot of different ways, especially with a lot of different versions of sex, right? Oral sex. And you treat it like you would treat mild incontinence, which is to say, if it's bad enough and maybe they have climacturia and mild stress incontinence, you do a sling. And maybe they just have climacturia, but they also have erectile dysfunction, you do an implant with that little mesh thing I talked about. The guy who has great erections, but just the climacturia, I don't have a mechanical way of fixing that. But maybe there's some adaptations that you can do. I don't know, Dr. Imholte, if you have ideas for that.
Yeah, absolutely. My experience with climacteria is like one, undoing the beliefs you have about urine, and two, right, being able to prepare for that, like you might just get a bed cover, just like you would for a child. And that is the indicator that, hey, we're going to have sex. We might integrate oil and things like that. So it's not just about the urine, right? It's not just about that piece, right? Because women have their own issues with urine,
Yeah.
physically, but it's creating the environment that says, hey, you know what? You're welcome here, even if there is some urine. There's not going to be a gallon of urine, right?
Right.
This idea, but usually there are beliefs that are already entrenched around urine itself, right?
Right.
So we work to create a space that welcomes the whole of all of it, right? And includes other things, whether it's oil or ice or, right? So it's not just about the urine. Mm.
That's a great point. I should use that. I guess the one physical thing I can think of is pee beforehand, and
Yeah.
you can always use for lack of a better term, a cock ring, right? Something crimping it off.
Right.
Yeah.
You could use those too. And some people are comfortable with that and some people are not. And there are very different kinds of, right? So if you were in my office, I'm going to pull out my cock ring basket, right?
Yeah.
Because I have multiple cock ring baskets,
Yeah.
right? And then you get to feel them and play with them and be like, I don't know. Or yes, I want to try this one, or maybe one with a vibrator, or maybe one that looks different,
Yes.
right? But I think certainly when I'm working with couples and or men, individuals, I encourage that physical therapy happen before anything happens. So, like Dr. Sun was saying, I do a lot of watchful waiting with people, right? And during that time, it's really then you can create the physical therapy relationship. So you're working on the pelvic floor already, right? And the other piece that helps is like doing couple yoga. So partner yoga is designed to actually build trust, right? And what I see happen is like, if we stay with heterosexual couples, right, the woman will say, oh my gosh, he's going to die. It's cancer, right? And then there's a surviving. Well, he's not dead. And now I don't know what to do, right? And he's wanting to use his penis more than he ever had in the past, right? And so then that becomes a really couple issue. Mm, mm.
Great. Yeah.
Yeah, so it's like you can do those PT, you can do that ahead of time. Couple yoga is usually in the community. It's a great way to take some risks, to be very playful, to not try to get it perfect, right? All of those kinds of things. And couples really benefit from that prior to any kind of treatment. Mm.
Totally. That's great.
Thank you for that. Appreciate both of those perspectives and responses. Dr. Sun, you said that implant lasts, maybe 15 to 20 years. What happens that makes it no longer viable, and what does the patient do then?
Sure. Like any mechanical device, things can break. Usually the breakage that happens is that somewhere it pops a leak and the fluid leaks out. The fluid is 100 milliliters of normal saline. So 1/10 of a bag, like the IV bags that you would hang in the hospital. Completely harmless. Your body absorbs it. At that point, the implant is no longer functional, but it's also not dangerous. So if several situations, it still works, but you just don't want to use it anymore, then you just leave it deflated and be about your merry business. A lot of people don't deflate it to zero. You leave it like 40% inflated just because it looks nicer. If it pops a leak and it breaks, either the guy wants to still use it and I just take it out and put a new one in, or he doesn't use it anymore and we just let it be. But it's not dangerous. You just let it be.
Okay, thank you. Is there any hope, and I know your answers will be yes, because you've already kind of said that, for having an orgasm with more feeling and perhaps with actual ejaculation? Dr. Imholte, you can lead
Well,
us.
definitely with more feeling, right? So the more attuned you can be to the whole of your body around its sensation, which requires you to be really present. There's a whole phenomenon called spectatoring, where you're sort of above watching, like, is it going to get hard? Am I going to get hard? Am I able to enter? Right? Where you're sort of out of your body then, and you're watching yourself. So one is to enhance sensation, and the PDF that I attach has lots of exercises, but I might like ask people to actually play with ice, not just on their genitals, right? But to create sensation throughout the body, because you can have a full body orgasm, which is amazing, right? that has nothing to do with semen or ejaculate, right? And that can last longer than the ejaculation that you would have if you didn't have a whole body orgasm. So you have a lot of potential there to really stretch that out. Once you are able to attune more to your body instead of watch your body to see if it'll work or not.
Yeah, I think from our sort of anatomical standpoint, I can't tell you that I could say yes and use the word ejaculate, because by definition, ejaculate is produced by the prostate, and the prostate is either gone or it's basically fried, right, with radiation. Usually, radiation patients will notice a slow decline in their ejaculate volume until it just disappears one day. But the orgasm thing, absolutely. And the other thing is, orgasm is influenced by a lot of different hormones. Testosterone is certainly one of them. Let's say 10, 15 years ago, when I was in training, if I had said even potentially you might give a guy with prostate cancer testosterone, they would have kicked me out of residency. Nowadays, things are very different. We have come to the realization that testosterone is important for a lot of things. Yes, there's a theoretical risk there, but normalization of testosterone can be more beneficial to the body than artificially keeping it low, except in the case of metastatic prostate cancer. Then you have to. But in a guy, let's just take a guy who's like, his prostate's been gone for 10 years, his PSA has been undetectable for 10 years, and he has low testosterone. We shouldn't be as afraid as we used to be about giving them prostate testosterone, because the dude doesn't have a shred of prostate cancer cell left in his body, right? So I am pretty liberal with it. A lot of urologists aren't, but many of us have started to come on board with the idea of potentially supplementing testosterone in these patients. It's gentle. It's not usually super blasting hardcore, but you can do it, and it can be a big help. But you got to talk to your individual doctor about that, because there are some risks.
Well, thank you so much. That's a great place to end our conversation, mostly because we're at time. I feel like we could go on and on. There are still more questions, but you guys did a great job of answering them. So thank you so much, Dr. Sun and Dr. Imholte, for an informative discussion. As we close today's webinar, I want to remind everyone to please fill out our short survey and to look out for an email with the recording of today's webinar in case you'd like to share it or listen again. I also want to put in one last plug for our virtual summit in June. There will be 2 different sessions covering ED and incontinence, one presented by physical therapists, so you can get the perspective. You can hear more about pelvic floor therapy, which is another tool to manage both of those, and one continuing with the discussion of relationships and intimacy. There will be support groups covering penile rehab and side effect management as well, in addition to the many other topics covered. Thank you for joining us for this important discussion, and we hope you have a great evening. Thank you.
Thanks, everyone.
Thank you all. Take care.